Welcome back to my channel Mis.Medicine. Today we will discuss about interpretation of chest X-ray, basic interpretation. X-ray are a type of the radiation which called electromagnetic waves. In this lecture we will study about X-ray, what is X-ray and which parts we can see in the X-ray, about their colors, black, grey or white. Second, we will discuss about the abnormal findings in chest X-ray. We will also discuss about the anatomy of the chest, normal anatomy, what we can see in the chest, about their anterior and posterior, anterior-posterior and posterior-anterior view. We will also discuss about the quality of the X-ray. Quality of the X-ray. We will discuss about different diseases we can see in the X-ray, and at last we will discuss 20 cases with X-ray.
What is X-ray? X-ray, it describes radiation which is part of the spectrum which includes visible light, gamma rays and cosmic radiation. Unlike visible light, radiation passes through stuff. When you shine a beam of X-ray at a person and put a film on the other side of them, a shadow is produced of the inside of their body. Different tissues in our body absorbs X-rays at different extents, like bone, tissue and air. Bone have high absorption, which shows in white.
We will see in the X-ray bone in the white color. Bone have high absorption. We will see tissues which have middle absorption, not so high, not so low. We see grey color of tissues in the X-ray, and last is air, which in the black color. Have low absorption, have middle absorption in the tissues, and bone have high absorption of the X-ray or
Tissue, somewhere in the middle absorption, shows grey color, and air, low absorption, which shows black color. You can see in this X-ray bone, air and water. Air is the black color, bone is white color, and water or tissues. Essentials before getting started. First is exposure and second is sex of the patient. Exposure like overexposure or underexposure. Sex of patient like male or female. In this X-ray, patient is female. Why? Because you can see breast in the lateral border. Be systematic. We have to check the quality of the film. Systemic approach. We will see in the chest X-ray or in the X-ray like bony fragments, ribs, sternum, spine, shoulder girdle or clavicles. You can see in this X-ray also vertebra, rib, posterior or anterior, sternum. Film quality. How we check this is the good quality of the film or something else. First determine is the film a posterior anterior or anterior posterior view. In posterior anterior, the X-ray penetrate through the back of the patient onto the film. And anterior posterior, the X-rays penetrate through the front of the patient onto the film. Posterior anterior, from the back and anterior posterior from the front. All X-rays in the PICU are portable and are anterior posterior view. Was film taken under full inspiration? Is the question. 10 posterior ribs should be visible. Why do I say posterior here? When X-ray beams pass through the anterior chest on the film, under the patient, the ribs closer to the film posterior are most apparent. A really good film will show anterior ribs too. There should be 6 to qualify as a good inspiratory film. This is the X-ray. You can see. How to verify right and left sides. Gastric bubbles should be on the left for always. You can see in this picture thyroid cartilage, thyroid gland, trachea, humerus, border of left ventricle, dome of diaphragm, xiphoid cartilage, pleural reflection, infrasternal angle, costal arc, right border of the heart, axillary fold, coracoid process, acromion, clavicle, and apex of lung. Look at the diaphragm. For tenting free air abnormal elevation, margins should be sharp. The right hemidiaphragm is usually slightly higher than the left. You can see in this is higher. Pitfalls to chest X-ray interpretation: poor inspiration, over or under penetration, rotation, and forgetting the path of the X-ray beam. Check the heart. Size, shape, silhouette margins should be sharp. Diameter, more than half thoracic diameter is enlarged heart. You have to remember that anterior posterior views make heart appear larger than it actually is. You can see this picture of X-ray. First one, you can see right atrium. Second one, here is right ventricle. Third is apex of left ventricle. Fourth one is superior vena cava. Fifth one is inferior vena cava. Sixth one is tricuspid valve. Seventh, pulmonary valve. Eighth, pulmonary trunk. Ninth, right pulmonary artery. And 10th, left pulmonary artery. You can see in this X-ray loss of cardiac border and consolidation. This is the anatomy of the lung: apex of lung, groove of aciocephalic and subclavian vessels, upper lobe, lower lobe, middle lobe, oblique fissure, trachea, anterior segment bone, anterior margin of lung, apical posterior bone. How we will check the costophrenic angles? Margins should be sharp. Loss of sharp costophrenic angles. This is the X-ray of loss of sharp costophrenic angles. You can see in this picture. Check the Hilar region. The Hilar region, the large blood vessel going to and from the lung at the root of each lung where it meets the heart. Check the size and shape of the aorta, nodes, and enlarged vessels. You can see pulmonary vascular congestion, cardiac pulmonary border, cardiac border enlargement. You can see in this picture pulmonary vascular congestion, cardiac border enlargement, pulmonary vascular congestion, and cardiac border enlargement. White. We will check the lung fields like infiltrates, increased interstitial markings, masses, absence of normal margins, air bronchograms, increased vascularity. Lung anatomy on chest X-ray. Posterior anterior view, extensive overlap, lower lobes extended high, and lateral view, extent of lower lobes. Lung anatomy on chest X-ray. Right upper lobe. The right upper lobe occupies the upper one-third of the right lung. Posteriorly, the right upper lobe is adjacent to the first 3 to 5 ribs. Anteriorly, the right upper lobe extends inferiorly as far as the fourth right anterior rib. Right middle lobe is typically the smallest of the three and appears triangular in shape, being narrowest near the hilum. The right lobe is the largest of all three lobes, separated from the others by the major fissure. Posteriorly, the right lower lobe extended as far as superiorly as the sixth thoracic vertebral body and extends inferiorly to the diaphragm. Review of the lateral plane film surprisingly shows the superior extent of right lower lobe. Lung anatomy on the chest X-ray. The lobar architecture of the left lung The lobar architecture of the left lung is slightly different than right. Because there is no defined minor fissure, there are only two lobes on the left and the left upper. Left lower lobes. These two lobes are separated by a major fissure identical to that seen on the right side, although often slightly more inferior in location. The portion of the left lung that corresponds anatomically to the right middle lobe is incorporated into the left upper lobe. These lobes can be separated from one another by two fissures, major fissure and the minor fissure. The minor fissure separates the right upper lobe from the right middle lobe and thus represents the visceral pleural surfaces of both of these lobes. Oriented obliques, the major fissure extends posteriorly and superiorly approximately to the level of the fourth vertebral body. Describing abnormal findings on a chest radiograph. When addressing on abnormal finding on a chest radiograph, only a description of what is seen rather than a diagnosis should be presented. A chest radiograph alone is not diagnostic but is only one piece of descriptive information used to formulate a diagnosis. Descriptive words such as shadows, density, or patchiness should be used to discuss the findings. Liquid density or increased air density. Liquid density divided into two, generalized and localized. In generalized, diffuse alveolar, diffuse interstitial and mixed and vascular. 4 types in generalized liquid density. In local liquid density, infiltrate consolidation, cavitation, mass, congestion, atelectasis. Increased air density, localized airway obstruction, diffuse airway obstruction, emphysema and bulla. Common abnormal findings in chest X-ray like Silhouette sign. What is Silhouette sign? The loss of the lung's soft tissue interface due to the presence of the fluid in the normal air-filled lung. If an intrathoracic opacity is in anatomic contact with the border, then the opacity will be obscured that border. Commonly seen with the borders of the heart, aorta, chest wall and diaphragm. You can see in this picture, this is Silhouette sign. Next is air bronchogram, a tubular outline of an airway made visible due to the filling of the surroundings alveoli by fluid or inflammatory exudates. Condition in which air bronchograms are seen, like lung consolidation, pulmonary edema, non-obstructive pulmonary atelectasis, interstitial diseases, neoplasm, and normal expiration. You can see in this X-ray. Next is consolidation. The lung is said to be consolidated when the alveoli and small airways are filled with the dense material. This dense material may consist of pus, fluid, blood cells, pus pneumonia, fluid pulmonary edema, blood pulmonary hemorrhage, and cells can be cancer. Consolidation, Lobal consolidation, alveolar space filled with inflammatory exudate. Interstitium and architecture remain intact. The airway is patent, and radiologically a density corresponds to a segment or lobe, air bronchogram, and no significant loss of lung volume. You can see in this picture consolidation. Next is atelectasis, almost always associated with a linear increased density due to volume loss. Indirect indications of volume loss include vascular crowding or mediastinal shift towards the collapse. Possible observance of hilar elevation with an upper lobe collapse or hilar depression with a lower lobe collapse. Hilar elevation, upper lobe collapse, and hilar depression with a lower lobe collapse. Atelectasis, loss of air. Obstructive atelectasis, no ventilation to the lobe beyond obstruction. Radiologically, density corresponding to the segment or lobe, significant loss of volume, and compensatory hyperinflation of normal lungs. You can see in this picture atelectasis. Next is pneumonia. Typical findings on the chest radiograph include airspace opacity, lobal consolidation, and interstitial opacities. You can see in this picture. Another one is also this one, 3. Pneumothorax appears in the chest radiograph as air without lung markings. In a posterior anterior film, it is usually seen in the abscess. Since the air rises to the least dependent part of the chest, the air is typically found peripheral to the white line of the visceral pleura, best demonstrated by an expiration film. You can see in this picture. Next is pulmonary edema. There are two basic types of pulmonary edema: cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. Cardiogenic pulmonary edema, which caused by the increased hydrostatic pulmonary capillary pressure. Non-cardiogenic pulmonary edema caused by either altered capillary membrane permeability or decreased plasma oncotic pressure. Next is congestive heart failure. Common features observed on the chest radiograph of a congestive heart failure patient include cardiomegaly, cardiothoracic ratio will be more than 50%, cephalization of the pulmonary veins, appearance of curly B lines, alveolar edema often present in a classic perihilar bat wing pattern of the density. Pulmonary vascular congestion, cardiac border enlargement, pulmonary vascular congestion you can see on both sides. These are ECG electrodes. Next is emphysema. Common features seen on the chest radiograph includes hyperinflation with flattening of the diaphragms, increased retrosternal space, bullae, and enlargement of posterior, anterior, and retroventral core pulmonale. You can see. Next is lung mass. A lung mass will typically present as a lesion with the sharp margins and a homogeneous appearance in contrast to the diffuse appearance of an infiltrate. You can see in the effusion. On an upright film, an effusion will cause blunting on the lateral costophrenic sulcus, and if large enough on the posterior costophrenic sulcus, approximately 200 milliliter of fluid are needed to detect an effusion in a posterior anterior film, while approximately 75 milliliter of fluid would be visible in the lateral view. In the anterior posterior film, an effusion will appear as a graded haze that is denser at the base. A lateral decubitus film is helpful in confirming an infusion as the fluid will collect on the dependent site. You can see pleural effusion. Next is pneumothorax. Now we will practice the cases of X-rays. Case first. What you can see in this X-ray. Here, a single 3 cm relatively thin walled cavity is noted in the left mid-lung. This findings is most typical of squamous cell carcinoma, SCC. 1/3 of SCC masses shows cavitation. Case 2. LUL, lower LUL, left upper lobe, atelectasis. Loss of heart borders, silhouettings, notice overinflation on unaffected lung. Case 3. It is right middle and left upper lobe pneumonia. Case 4. This. Cavitation. Cystic changes in the area of consolidation due to the bacterial destruction of the lung tissue. Notice air fluid level. This is the cavitation. Case 5. Tuberculosis. Case 6. COPD, increase in heart diameter, flattening of the diaphragm, and increase in size of retrosternal air space. In addition, the upper lobes will become hyperlucent due to destruction of the lung tissues. Chronic emphysema effect on the lungs. You can see. Case 7. Pseudotumor. Fluid has filled the minor fissure, creating a density that resembles a tumor arrow. Recall that fluid and soft tissue are indistinguishable on plain film. Further analysis, however, reveals a classic pleural effusion in the right pleura. Note the right lateral gutter is blunted and the right diaphragm is obscured. Case 8. You can see this easily. Pneumonia. Pneumonia, a large pneumonia consolidation in the right lower lobe. Knowledge of lobar and segmental anatomy is important in the identifying of the location of the infection. Case 9. Cardiac heart failure or chronic heart failure. A great deal of attenuated interstitial markings, upper lobe vessels are prominent but are also marked by interstitial edema. Chronic heart failure, a great deal of attenuated interstitial markings, curly lines and an enlarged heart. Normally indistinct upper lobe vessels are prominent but are also masked by the interstitial edema. After 24 hours of diuretic therapy, you can see the difference. Now case 10. Chest wall lesion, this one. Arising of the chest wall and not the lung. Case 11. Pleural effusion. Note loss of left hemidiaphragm, fluid drain via thoracentesis. Thoracentesis, you can see. Case 12. Lung mass, you can see. Case 13. Small pneumothorax, left upper lobe. Case 15. Right middle lobe pneumothorax, complete lobar collapse. Post chest tube insertion and re-expansion. Case 16. Metastatic lung cancer, multiple nodules are seen. Case 17. Right upper lower lobe pulmonary nodule. Case 18. Tuberculosis. Case 19. Hilar mass, Hodgkin's disease. Case 20. Widened mediastinum, aortic dissection.